My husband was in treatment for 2 years with terminal colon cancer, but the only time anyone ever acknowledged that there was no cure for him was at his first appointment with the oncologist. From then on, the constant and cheerful refrain was, "There's always something in the cupboard." Although I don't wish to suggest that optimism and cheer are out of place at a cancer center, I have to tell you that it's crazy-making to be in an environment where no one can speak at all about death when that's the main thing you need help with. I recognize that this is a cultural phenomenon, since even people training to be funeral directors are told that they must never use the word death or any variant thereof because those words are too strong. But in a medical facility that treats 800 people a day with life-threatening illness, surely there should be some attention paid to the fate that many of them are facing. I'm a retired psychotherapist, so I'm not afraid of people's feelings, including my own. But sometimes I just need help with them. So I went to the social worker on staff at the cancer center, who was a very nice man, but the only item in his toolkit was to offer me a referral to a psychiatrist for an antidepressant. I wasn't depressed, I was sad. And I don't believe that sorrow is pathological, especially when you're losing somebody that you care about deeply. I didn't want a pill. I wanted support, and there was none. Of course, there came a time when, in fact, there was nothing left in the cupboard, but a referral to a drug trial gave the team that was looking after my husband a convenient way to claim that there was, which meant that everyone could still avoid talking about the obvious. When Fred came to sign the papers for the trial, a person that we had never met before told him it was a nasty drug, it wouldn't help, and that he should just go home and forget about it. So we left the building and every person that had been part of our support network for 2 years with no goodbye, no consultation, no discharge plan, no transition, and no idea whatsoever what would come next. Our team abandoned us when we needed them the most. 3 weeks before Fred died, our local palliative care team arrived on the scene, and we were told that the vast majority of deaths are peaceful and that we now had a primary contact. Whenever we needed anything, she was to be our resource. We never thought to ask about what a not peaceful death might look like. We had very few questions at all because, frankly, we had no idea what we were getting into. Fred said that he wanted to die at home, and it would have been just unimaginable for me to challenge that. I thought then, and now I can't even believe that I thought this, I thought that I could probably manage most things on my own. And if I couldn't, these kind people would be there and they would know what to do. What actually happened is one reason why I'm working with Canadian Virtual Hospice on a list of questions that people need to ask if they are considering a home death. Fred had a pain crisis almost immediately on a Saturday when the family doctor's office was closed. He was too sick to go to the hospital and he wouldn't have gone anyway. He wasn't willing. So I called our new contact person. She arranged a conference call with Telehealth Ontario herself and me. After 45 minutes of providing detailed medical history, I asked where this was going, and I was told that if I didn't cooperate and I had to call back, I'd have to start all over again. I said thank you anyway, and I ended the call. The navigator apologized and asked if I would like for her to call the family doctor, but I declined that, having already lost all faith in her, especially since the doctor had told me I could call the local hospital and ask them to call him directly. So Fred was so disgusted by this situation that he just insisted on trying to continue with the pain regime he was already on and just try to bear it. But by the next morning, we had to have help, and I called the hospital myself. Every time I called, the only number that's available to the public in my area for that hospital, I got a fax machine. After an hour of repeated dialing, I got through and I learned that the phone system had been out of order. Then it turned out that the family doctor had forgotten to put Fred's name on the list of patients they could call him about. However, after listening to my story, a nurse agreed to call anyway. And she called me back shortly and said the doctor was out, but that his wife would give him the message and he would be back in 15 minutes. I waited a few hours, but we heard nothing, so I called the number that a specialist had written on a business card for me as a backup in an emergency, since I felt that this was now an emergency. I left a message and I waited some more. As I reached total desperation after 24 hours with no help at all, I called the after-hours number at the cancer center where Fred had been treated, and I chose not to tell them that he was no longer a patient there, which fortunately they didn't realize. A doctor there called me back in 15 minutes, and we finally got the help we needed. At 11 o'clock that night, the family doctor called. His wife had forgotten to give him the message. 2 days later, I learned that the specialist had written down the wrong phone number. And I'm sorry to tell you that there is no longer a 24-hour helpline at the cancer center. Does this sound to you like a system that was designed by or for the people who use it? Is it a system at all? This is why I've been campaigning, even in Salzburg, for every family that undertakes to have a loved one die at home, to have a reliable number to call 24 hours a day to access help when you need it. I'm aware that some areas do have this, but it's far from universal. I was at a recent brainstorming session at the same cancer center where my husband and son were treated in my area that was focused on identifying gaps in palliative care. When I made my impassioned plea for this 24-hour service, a palliative care physician said, "Oh, we can't do that." And I said, "Why ever not?" And she said, "Oh, that number changes so often, we don't even know who to call." So you can see where I'm going with this. For a system to work well, the people who use it need to be consulted. For palliative care, that means checking in with patients as they're dying to ask what they need. After patients die, it means checking in with their families to see how it actually went. And after that, it means working with people like me to help design better systems from the beginning. I'm so happy to tell you that Pallium has taken that message seriously, which is why I've been a member of the National LEAP Advisory Council for the last 2 years, and I'm so excited to be working with these wonderful folks on a LEAP curriculum for caregivers, as well as ways to include local families in regular LEAP training courses in order to provide better quality improvement, targeted quality improvement. The parts of my story that I've shared with you, as difficult as they were for us, were not the really hard parts. They came later. But I will not be telling you about those today because the whole story is too hard to tell and it's too sad to hear. For a long time, I told an abridged version in the healthcare settings where it seemed as though it would do a lot of good. I hope it did do a lot of good. But eventually, I realized that in order to make that story socially acceptable, I had edited out the very things that were the hardest to hear. And I did that because I was ashamed. I'm going to say that again. I was ashamed. If you're not a therapist, that might surprise you, but many, if not all of us who've suffered a loss experience this feeling. Where death is concerned, we are all ashamed. Patients are ashamed because they're dying. Doctors are ashamed because they feel they've failed. Mourners are ashamed because our sorrow is just too sad. Friends are ashamed because they don't know what to say. And we're all ashamed because we just can't figure out death and we don't know how to fix it. What do we do when we're ashamed? We hide. We cover our faces and we hope nobody sees us. We're even ashamed of our shame. And that keeps us stuck and alone. For those of you who are interested, I'd like to refer you to a wonderful book by Jeffrey Kaufman that discusses some of this called The Shame of Death, Grief, and Trauma, which clearly is never going to make it on the bestseller list with a title like that. One of the few things that helps us in this lonely place is to be able to talk about it, to metaphorically let the air get at it. But shame cuts us off from each other. In this crucial time when we're losing our most important connections, the rest of them get disrupted too. And if, during the approach to death, naming it is taboo, when it happens no one is there, and when it's over you're too ashamed to speak, the burden is crushing. A year after my husband died, our son Ted was diagnosed with an unrelated cancer. And I'm trying hard not to apologize for my tears because death is sad. One day, when Ted was getting his chemo, there was a man in a nearby chair who was in the same situation that Fred had been in the year before. We had spoken in the waiting room, so he knew that Fred had died. He was in the last stages of colon cancer, and he knew he didn't have much time left. When his wife went out for coffee, he beckoned me to come over to him, so I did, and I asked what I could do for him. He looked at me with terror in his eyes, and he said to me, "Could you tell me what it's like at the end?" I was taken aback and horrified, and I regret to this day that he had to see the look on my face. I was just not the right person for him to ask, but I was the only one he had. I managed to say that he had a good question and he deserved a good answer, and that I thought all deaths might be different, and he should ask the palliative care team in his area, and I devoutly hoped that there was one. Then I ran to the Wellwood office and I sobbed in a closet for an hour, for Fred and for that man and for every one of us. In the wake of that question, I resolved to do whatever I can to have a better answer to give the next time somebody asks me what it's like at the end. And I want to say to you that today I'm thrilled to be associated with an organization that shares the same goal. Thank you very much.